great to see everybody. Happy afternoon. It's great to see both of you, Grace, Dr. Hernandez. So we briefly connected earlier, and I said to Dr. Hernandez, do we want to do like a fun question? Do we want to like just dive right in? She is all business. She's super passionate about this. But I think it's probably...
I changed my mind.
Oh, you changed your mind.
As you're wont to do.
No, well, I think it would be most appropriate. We've got a ton of wonderful companies and sponsors, and so maybe it would be a good opportunity before we hear directly from both of you about your thoughts on this topic. Why don't you tell us a little bit about California Foundation Healthcare?
Well, great. Good afternoon. It's really nice to be here. And Christina, thank you for your remarks. I channeled my grandmother quite quickly, and resilience, tenacity, all of those nice adjectives. So thank you for sharing that story. It was really beautiful. The California Healthcare Foundation is a statewide healthcare foundation. I've been there as a CEO for about a dozen years. And really what we've been doing since I got there largely, but well before that, is trying to improve the actual delivery of healthcare in California for the roughly 14 million Californians that are on the Medi-Cal program. This is a program that I became familiar with when I came to UCSF in the mid-'80s, in the middle of the HIV epidemic. I trained at San Francisco General Hospital as a primary care internist. And really at the time, pretty much everybody we took care of at that hospital, and this is somewhat true today, were on Medi-Cal, or were uninsured, or were trauma patients and had great commercial care, because San Francisco General is, of course, a state-of-the-art trauma center. But it very much colored my sense of what was possible, both as a primary care clinician, but also just as an advocate for people for whom having a health insurance card, even if you're on Medi-Cal, does not necessarily mean you're going to get state-of-the-art care. We've talked a lot about people who fall through the cracks, and this is a hospital that had an enormous esprit de corps, but people do still fall through the cracks. And a lot of those cracks are the byproduct of policies that have existed for 30 or 40 years that really just make no sense, but that people continue to promote and practice. So that really was the beginning of my both work as a clinician, but also eventually work 12 years later as the director of public health in San Francisco, where really looking at the whole region and trying to understand the connection between public health and our delivery system. And so the California Healthcare Foundation really works in that space today. We do have an innovation fund, and I'll talk a little bit more about that, because one of the things we do is try to take people who have experienced these systems of care and have seen their family members struggle to access it, or have seen people fall through the cracks. And what we try to do is work both on policy and on practice to fill those in. And a lot of the innovation that we fund in growth stage companies come from people who've had that experience.
Great. Not bad for off the cuff, right? Grace, now I'm going to turn it over to you. Hopefully that gave you a minute to think.
Think about it, yeah.
So we've heard a little bit about Sutter Health and our Sutter friends. I love that in the front row. Grace, tell us a little bit about what you do in your role with Sutter.
Yeah, absolutely. So as mentioned, I oversee external affairs for Sutter Health. Sutter Health is one of the largest integrated healthcare systems in the nation, actually one of the top 10, and we extend all the way, I think, from the Oregon border all the way down to Santa Barbara. So we're pretty extensive, and hopeful that we have some patients in the audience today. But I've actually only been with Sutter, when I say only, I've only been with Sutter for 7 years. And before that, I was actually in the tech industry, and I had never worked in healthcare. And so, I think it's a great example of, you can work your entire career in one industry, and it really is possible to use those skills and to jump into another. So I spent, prior to coming to Sutter, I spent 18 years working for Intel, started doing local government affairs, and then by the time I left, I was running global public affairs, which included all of the government advocacy, as well as all of the work that we did in our external communities, like some of the STEM programs that were mentioned earlier. And so I was able to take the skills that I had gained in the tech industry and move it into healthcare. And when Sutter had reached out 7.5 years ago, it was really to build the public affairs, external affairs infrastructure. It didn't exist prior to that. And so that was really what interested me and also scared me, right? Because it's like you're walking into, an entity that has never had it, never done it. You kind of have to explain it, and then you also have to build it. I will tell you, it was probably the biggest risk of my career, but definitely the best. And so, I've never regretted it a day in my life, and I look at the front row full of my Sutter colleagues. I love healthcare. I feel like I have the best job in the whole company. But I also think that that's a philosophy with which you should live your life. You should feel like you have the best job in the company, and the day you don't is the day you want to go find something else to do, right? Because it's out there for you. So that's kind of my journey, but also, just a little bit about Sutter, and I know we'll talk a little bit more about that as well.
Great. I know we're going to dig into the technology in a moment. So, Dr. Hernandez, you talked a little bit about health equity. It's still a significant challenge. That's part of why you delved into the role that you did. So maybe let's explore some of the successful initiatives that you've been involved with that may have closed some of the gaps in healthcare access, particularly in underserved communities.
Sure. So, it's been, I came here 40 years ago, and many of the indicators around disparities, whether it's Black maternal health or immunization rates or breast cancer screening, pretty much any indicator that you look at, there are enormous disparities, racially, ethnically, culturally, linguistically. And so a lot of the work that we do at the California Healthcare Foundation is to really try to take the best that's happening in the delivery system that particularly serves the Medi-Cal population and tries to lift those up into broader collaboratives and initiatives across the state. The Innovation Fund that I mentioned, for example, you mentioned care coordination. There was a social worker, trained social worker, was working in a federally qualified health center for many, many years, was incredibly frustrated with the fact that behavioral health was over here and physical health was over there and drug treatment was over there. And really the system is not designed to do whole person care, let alone look at your whole family and try to figure out how all those pieces fit together. When there was a change at the federal government such that you could then bill for both behavioral health and physical health and care coordination and the navigators and the culturally competent people that can make those services come to life, she decided she was going to start a company. And so she started a company called Motivo, and it is very much focused on language access. It is a care coordination model that is evidence-based. It's scientifically based. It's been well studied. She came to the CHCF Innovation Fund and was looking for a way to expand it both in federally qualified health centers but also in public hospitals. And so what we do in our Innovation Fund is do low-interest loans over about a 5-year period. Sometimes we take out equity in the company. We require that we do an evaluation at the end of 5 years of our investment, and that whatever that evaluation showed, we would make public. But really our principal value add is to be able to connect them to the Medi-Cal delivery system, to health plans that serve the Medi-Cal population, to clinic consortiums, and to really help them grow their company. And so that is just one tool in the CHCF toolbox. We publish a tremendous amount of data. We have a Sacramento office where we do promote a lot of policy work. And we've been in the access to care, get everybody covered since the foundation started 26 years ago, and before that when I was in San Francisco, in Healthy San Francisco. And really today in California, the vast majority of everybody who lives in this state, regardless of your documentation status, is eligible for some form of health care, either Medi-Cal or Covered California. But again, for those services to be meaningful, You have to have a workforce that's culturally competent and that somewhat reflects the people that you're trying to serve. And so when Governor Newsom, before he first came into office, a number of the healthcare foundations for which California is rich in philanthropic organizations in healthcare, we decided that we would come together and develop a comprehensive workforce plan for the state of California looking at 2030 as our target date. And that really focused in 3 principal areas in behavioral health where there is just an enormous need for healthcare providers at all levels, primary care, for which we are wildly underinvested, and then services for the aging population. And that workforce plan also called for a new office in California. And before the state budget went into the tank, there was a significant investment, and the Office of Healthcare Affordability and HCI was formed. And now we have a mechanism by which we track against those goals. And all the healthcare philanthropies have picked the areas that they have decided to lean in the most. California Healthcare Foundation is doing a tremendous amount of work on doulas, on community health workers. We've done psychiatric nurse practitioners to allow people to be able to prescribe medications in partnership with UC and UC Merced. So in order to have access for a state as diverse as California, you also have to obviously invest in workforce. And so that is a big part of CHCF's work, trying to address some of the inequities that we continue to see.
Congratulations. It sounds like tremendous impact. Grace, so you mentioned it in your opening. Your technology background may be unique to the role that you have, but may be incredibly valuable. So help us understand what role technology plays in advancing health equity, and any advice on how do we better leverage this to improve access?
Yeah, it's a great question. So, I always believe that whenever a situation occurs, there are good things that come out of it, right, and challenging things that come out of it. And so when you look at COVID, right, definitely that was not something that anybody would say, yay, that was the best time ever. But there were good things that came out of it in the sense of, from a telehealth perspective. We had been having conversations at the federal level with elected officials about really, ways in which we could get telehealth when it comes to healthcare just to really flourish. And COVID, for good or bad, I think really forced people, to use telehealth with regards to get their healthcare delivery. And then also what we also recognized was, that is something, one, that can extend outside of obviously the pandemic situation, but also it's an incredibly good way to make sure that you're reaching rural areas, right? Because as we've talked about and we'll talk about again in terms of the workforce shortage, rural areas and rural populations don't necessarily have the same access to clinicians. So telehealth is a great way for us to try to level that playing field. And I just, kind of want to tag on to what was just said about there's a difference between health equity and health equality, right? And so it's really important for us to make sure that we understand what it is that we're talking about, because you can also have a community where they have access to the same health care, but it's not necessarily equal because their home situation or, they may not have access to refrigeration in terms of some of the medication that they need to take. It's really important to make sure that we're talking about equality, right? So that we make sure that people get the same level of health care in the way that they need it. I think from technology, I think is a great equalizer in that sense. We're very proud of, in my organization, we also oversee our community health and our community benefit work that we do with our FQHCs, the federally qualified health clinics. They provide such an incredible need in our communities because it's one thing for somebody to come into an emergency room and they receive the health care that they need, but by the time you get to the emergency room, it's probably your worst case scenario, right? You want to keep people healthy. we're able, in partnership with our FQHCs, to be able to, when we release them, so that they actually have that warm handoff with a nurse navigator that you were talking about, where they can go to an FQHC and they can actually receive that wraparound care. So I think for us, it's really important, even from a technology perspective, to make sure that we're working, not just Sutter, right, not just Kaiser or any other healthcare system, but that we're working with our community partners. And I think it's one of the things that we're really proud of in terms of how we engage.
Great. So both of you mentioned, I think, an intersection here. Post-pandemic, we in the Bay Area are dealing with workforce shortages. It's impacting, I think, every company, every industry, but certainly healthcare. It's been devastating. So curious, what strategies each of you might be employing or see as best practices in diversifying for the field.
Yeah, well, I'll start on this. I would say that one of the policy challenges that we've had in California is that, doctors don't want nurses to do things that doctors only do. And so there's a very provincial way in which we sort of think of, not in my tent, here are the lines. And my whole philosophy and our philosophy in general is we need every drop of workforce we can get, number one. Number two, the comments about how important it is. I can remember when I was director of health, I would run into one of our health education employees in the hallway, and we'd start chatting, and, what are you doing? Well, I'm taking a couple of pre-med classes. Well, okay, so you're going to go to medical school? Well, I don't really know anybody who went to medical school, right? And so part of what we need to do, and COVID was in some ways an opportunity because everybody saw healthcare and public health up close and personal in their families. And so it was really an opportunity to inspire folks in high school. I think the high school programs are super important. I'm thrilled that Genentech is doing that. We should be scaling that because if you have never seen the inside of a hospital or the inside of an urgent care facility or an FQHC and you don't have any way of knowing how you fit in. So we have a tremendous amount of work to do in pipeline programs. There's an initiative in the state. The state is majority minority state. When I first got to San Francisco General as an intern, there were 5% of the population were Latino physicians, and today it's 6%. And so there's an initiative being led by multiple health plans, multiple delivery systems, multiple philanthropies that are trying to grow Latino physicians so that it is more reflective of the community we serve broadly. Excuse me. And there are initiatives like that. LA Care is an enormous health plan in Los Angeles. They have an enormous workforce project. Inland Empire Health Plan. They're investing in community health workers as extenders. And so really there are initiatives that are high school, that are STEM. We did a big project to try to look at how California could grow more graduate medical education spots. There were hospitals that, because Medicare largely funds GME, that's an oversimplification, but for the most part. But there are hospitals who had never applied to Medicare for graduate medical education programs. And so trying to expand GME so that we have more slots for physicians to be able to come in and train. One of the companies that CHCF invested in, because in order to get clinical social workers, you have to have clinical oversight and hours, but there weren't enough places where people could get that training. So a woman started a company where you could get that training online. That would count for hours so that you could increase the pipeline of clinical social workers. So I think it's a combination of technology, it's a combination of our pipeline programs, it's looking at every place where we have a lot of people who have talent but fall out because they don't have the resources to continue. Or they finished college, they want to apply to medical school, they take a year, they take a job, maybe 2 jobs, they're trying to get back in the workforce, they need resources. So I think it's really important to look at the entire pipeline, all of them, by the way, pharmacists, nurses, physician assistants, they all have their own pipelines. And really, you got to be able to invest in the initiatives that people are working on in that space. We heard from the dean at UCSF School of Pharmacy. They were looking for placements. Turns out that the jail and prison system in California has a shortage of pharmacists, and so they're placing people in those positions to get pharmacy training. And we really need to be able to think creatively about how we increase that pipeline across the board and leverage technology, as that's been said. Telehealth that you mentioned, which is just funny because we had been studying telehealth and trying to make the case that it was the right thing to do from a policy and from an access point of view. We'd studied it for 5 years. We had gone to the board just before 2020 and said, telehealth has got no place to go. We're going to fold this portfolio. And then the pandemic happened, and we just pulled the portfolio out and invested $5 million in a month in telehealth through UC Davis's program to really focus in rural areas. And so sometimes you have to ready policy because you never know when that policy window opens. And being opportunistic in that way, I think, is super important to be able to do. And have a governing body that's willing to go with you is also super helpful.
This lends a new twist on being flexible and agile when you're adapting to a boat moving. Grace, I mean, this
point's been made.
Good illustration. I love it. So, Grace, how is Sutter Health adapting to the workforce shortages? What are you guys doing?
Yeah, no. So since we're on the telehealth, I firmly believe that timing is everything, right? And so, what was the difference other than the pandemic was it was also that the government made it reimbursable, right? And so that's another piece too, right? I mean, if you're not going to get reimbursed, doing a visit over telehealth versus in office, then it really forces, the in office, right? Which isn't necessarily always the most convenient for the patient or the physician, right? So that's why also being engaged from a policy perspective is so important. Otherwise, you're not going to be able to get it to take off. But, newsflash, we have amazing jobs in healthcare, and y'all are welcome, right? And what I mean by that is, so, Sutter is actually 80% female, and our board of directors is 50-50 female. Our senior leadership that reports directly to the CEO is, I think, 50-50. It might be 60-40, somewhere in there, female. Healthcare is a great industry to be engaged in if you are female, all the way, from, whether you want to be a rad tech to a physician, all the way in terms of the ecosystem. And so some of the things that we're really proud of, we have just developed a program called Next Gen Scholars. And the reality is that not everyone really wants to go to college or needs to go to college in order to get a really good paying job in healthcare. And so we have developed a program where we're partnering with our community colleges as well as our high schools, because one of the things that we've found, or that I think a lot of folks know, is that so a student going to community college, the average age is in the 30s. So typically what happens is they graduate from high school, they have a series of jobs for 10 years, and then they decide to go back to community college to get, to get additional training. Well, what if we could shorten that 10 years? Because what if, let's just imagine, if you're in high school and you know that college is not for you, you can take certification programs that by the time you, at the community college, that by the time you graduate from high school, you actually have a certification and you can go right into healthcare, whether it's an MA or a rad tech or any type of those other jobs where it really is the certification that you need. So we're partnering with our community colleges and our high schools to introduce that program. So we have a pilot right now that we're going to be starting. And it also means that we are also going to be, teaching them interpersonal skills. And we're not just saying, here's the class, right, and you're on your own, but it's also working with them throughout the entire stage so that by the time they graduate, they're ready to go, right? I mean, we have high school signing days for athletes. Well, what if we had high school signing days for people going in, high school kids going into healthcare, right? I think that's the vision that we have, and those are the programs that we're looking to build that we're really excited about right now.
Wonderful. The programs that are paving the way to provide access, visibility, diversity, tremendous.
And I would just add, what I love about healthcare, my observation has been, it really is an ecosystem of jobs, right? You get that first job, and you can spend your entire career inside the same system. We have a lot of people who started as, an MA, and they've done so many different jobs inside the company, or they've gone back to college. They become, they have their certification, they work at Sutter, and now they decide, well, I'm going to go back to college, right? And so we have those programs as well that help support them through that.
Love it. So last two questions, and depending, I'm going to look, this is the signal. If we have time for audience questions, I'm told to ask for that. But I'm curious, careers or journeys, they're all about exposures and opportunities. So I'm wondering from both of you, was there a pivotal moment in your career that shaped your leadership style? Because obviously your stories depict resilience, fortitude in an ever-changing healthcare environment. So what was it for you that kind of led you to this path?
Well, it's been a long path when you're my age, so I'll just say that. But, we're talking about a pipeline, and I think it's super important. I went to a very large urban public high school in the Southwest. I was planning to go to college, but the vice principal called me in one day and said, here, why don't you apply to this Ivy League school instead of the school that was 2 miles from where I grew up. That took me to an Ivy League school, and then when I was there, I'm a junior, I'm studying psychology, and a professor and his wife took me to dinner and said, why don't you apply to medical school? It had never occurred to me to apply to medical school. Actually, they started with, what are you going to do after college? And, there were psychology professors, and I was a psychology undergrad, so I said, of course, I'm going to go get a PhD in psychology. And they're like, no, actually, you should apply to medical school. And, it happened. I liked math, and I liked science, applied to medical school, and then really came to San Francisco, which is really just an extraordinary place for healthcare and health experiences. So I was very fortunate to match here at UCSF. And in that hospital, the opportunity that you have to advocate for things that are unjust and not right, and there are many of them in all the systems in which we operate, in our educational systems and our healthcare systems. There was an esprit de corps in that hospital that said, really, if you see something, do something about it and make it better. And so I had a patient that, as a primary care intern and resident, that was actually my age at that time. We were exactly the same age. She had polycystic kidney disease. She happened to be undocumented, and it happened to be the policy at the time that we wouldn't dialyze a patient if they were undocumented until they were entirely ready for an emergency. I thought that was outrageous, and so it turned out there was a health commission that Mayor Feinstein had put in place, and Dr. Phil Lee was the chair of, and I found out that they met every other week, and showed up there one day and told the story and said, like, I don't know where, first of all, the policy's not written down anywhere. If anybody, you say, well, where's the policy written down, and who wrote it, and when was it written, and who last approved it? Answer is, I don't know, it's just what we do, it's the policy. And there are a lot of those. and so Dr. Phil Lee heard, you sign up for 2 minutes at the back of the room. And by the way, now I serve on commissions where it's really important for me to hear what people sign up for 2 minutes to tell us about affordability or about what we should do around primary care access or the like. And I learned that because I used to be at the back of the room signing up for 2 minutes to sort of say this is wrong. And that was really the bite that got me interested in public health and public health policy. And then I just had many great mentors along the way, some men, some women, but I think all of them to a one really taught me two things. One, of course, is to, yes, use what you experience and what you see and what the story and the anecdote is, but also have the data. right? We need to have both of those. And the foundation, we do publish a lot of reports, but we also tell a lot of stories, and we write a lot of blogs, and we interview a lot of people, because you need both of those to be able to move and influence policy. And so I had mentors that sort of said, you've seen the stories, you have the stories, you know them, you're trained in data, you're trained as a scientist, so use both of those skills to make the change that you want. And that has taken me on an enormous journey for which I have never one day been bored. Mentors come in different shapes and sizes and fashions. And what I learned to do was sort of take the best of what I could see and try to incorporate them as best I could with given what my value set was, how I was raised, and the change that I wanted to see. And so mentors come in a lot of different fashions. Find them. They might be useful for a year or 2 years or 3 years. Someday I'll write a book about mentors, because I think it's important to sort of tell the story about formal ones and informal ones. They exist all around you.
Wonderful. All right, before we turn it over to Grace, because I'm going to ask her the same question, I do now see the clock in front of me, so good clue. I do think we've got some time for questions, so get ready with your questions for these two amazing women leaders. But Grace, you want to tell us about your leadership journey?
Yeah, and I think I would just go back to what I said in the beginning. I think for me it was making the shift from tech to healthcare, to seemingly unconnected, right? And I think what I learned is in tech, and especially the company that I was at, it was founded by engineers, right? Very logical. A plus B will always equal C. And then going necessarily so, right? And then moving into healthcare, where nothing made sense, right? In the sense of A plus B doesn't always equal C, because there may be a reason where it needs to equal D, right? Because you're dealing with people, right? And you're dealing with what they have going on in terms of their healthcare journey. And that was an incredibly, I think for me, from a professional perspective, it really, I think, gave me an understanding of the importance of leadership, because you also have to be, I was a leader in a tech company, and now I'm a leader in a healthcare company, and you also have to make sure that you're meeting people where they are. The way that I would engage in a tech company is very different than in a healthcare company. And so it's always important as a leader to remember, you got to meet people where they are, right? And you've got to bring them back to where you need them to be. And I'll just close with, yesterday I was scrolling through LinkedIn, and I saw this really great post. It was a photo of this, it must have been like a Lamborghini or something, and it was in a swamp. And it was stuck in a swamp. And the caption said, "It's important to remember that your environment matters." Meaning you can be the most incredibly talented person, but it's also important to make sure that you put yourself in the right environment, right? And so I'm a firm believer in who you work for, who you work with is incredibly important. And I also, tell folks that I mentor is that, success is very subjective. Nobody has the right to tell you what the definition of success is and then demand it of you. Right? So what might be my definition of success is very different than your definition, but one is no greater or less than the other, right? And so it's really important to remember and not get caught up in that your leadership journey as defined by someone else. It has to be defined by you. And I think sometimes, you kind of forget that. And it's really important to kind of pull yourself back and remember that you're living your life versus somebody else's. And like I said, I think I have the best job in the company. Somebody else may think it's the worst, right? So it really does depend, and it's very subjective.
There's a lot of opportunities. Let's get these ladies a round of applause.